Hello, I'm Dr. Biomarker from City of Hope. And as I stated last week, we're going to be talking the next several sessions, this session and the next session, a little bit about some unique questions that come up in the mind of oncologists and others as relates to precision cancer medicine that are now coming to the fore because precision cancer medicine has become a standard component, a major standard component of standard of care in the management of patients with cancers. So the question I'm going to address very briefly, all too briefly, because it's quite complex, is what is the optimal timing of obtaining such testing in a patient who is diagnosed with cancer? Obviously, this is a very complicated area. There will be very unique answers for individual tumor types, different stages of disease. But in general, I would say I would divide this question in terms of my response into three general categories. The first is will be those tests that are necessary for immediate therapy that's going to be starting today. And when I say today, obviously, I don't mean necessarily only today, but it could be over the next week or so. Examples of that would be knowledge if a patient has an EGFR mutation or an ALK rearrangement. It is critical that that information is known in a patient with non-small cell lung cancer, metastatic disease now, because we have very good evidence that starting a patient on a targeted therapy, if that's appropriate based on the biomarker, is going to have a major favorable impact on their outcome statistically compared to starting them on chemotherapy and maybe getting that answer in a month. So there's an example of a test that we want to have it done right away. We want the sample right away. We want to have the testing done right away. So whatever testing platform is used, whatever company is used, whatever in-house lab is used, that information needs to be available now. And when I say now, I mean within days. And a week is probably about as long as you want to wait, if not shorter. On the other hand, there are other types of tests that are necessary, that are critical, that it is not necessary to know immediately. Second-line therapies might be determined by this. The use of maintenance type strategies. Here, it is very reasonable to suggest that if the testing platform, the test is obtained, testing is obtained, and you get that information in 3 weeks, 4 weeks, done very correctly, interpreted, obviously, with caution, that's perfectly reasonable. Ovarian cancer is a very good example of that, where we're talking about the use of PARP inhibitors as a maintenance strategy. It's not started when you first initiate therapeutic regimen in an individual patient. It's a maintenance type strategy. So you have that information. And waiting that period of time for that information is perfectly reasonable. Also potentially waiting to find out if a patient has responded to treatment, as opposed to not responding to treatment where this type of maintenance therapy would not be relevant. Tumor agnostic testing for second line, third line types of therapies. Again, that information can be available several weeks after you decided to obtain the test. And finally, we turn to that very broad category of germline testing. Now, that germline testing may be very relevant for the management of that individual patient. Again, PARP inhibitors in ovarian cancer or breast cancer are very good examples. But here, the question may be more complex because we are also talking about the impact on family members if a germline mutation is obtained. And so it's not only the discussion with the patient about themselves, their management, that family, it's also their larger family. There may be patients who are very willing to go ahead with that testing, germline testing, immediately, within days or weeks of the diagnosis. There may be other families where it becomes critical to get that information at a later point in time, having that discussion at a later point in time. That's going to vary. So that third category, germline testing, my suggestion is it's much more heterogeneous in terms of the patient population that one is dealing with. And you have that time in general and it has a different thought process. So here, again, I'm just trying to emphasize the complexity of the testing and when you might consider obtaining these tests in individual patients with cancer. I thank you for your attention. I look forward to our next discussion about the topic of theoretical concerns that might come up or questions that are asked about this whole question of molecular abnormalities present in the germline or in the tumor. And I thank you for your attention.